Welcome everyone to Cook Medical's Otologic Case Review webinar. My name is Nicole LeBlanc, Cook Medical's Otolaryngology Global Training Manager. I'm going to be here to introduce our moderator and to assist with live questions. Our speakers will discuss their experiences in interesting cases around minimally invasive otology. Our moderator, Dr. Ken Kazahaya, is the Associate Director and Associate Professor in the Division of Pediatric Otolaryngology at the Children's Hospital of Philadelphia. We would like this to be an interactive event, so please ask questions as they come up. The Q&A function can be found on the top right-hand side of your screen. Please don't wait until the end to post questions, as there is a slight delay for us to see them. With that, over to you. Welcome, Dr. Kazahaya.
Good morning, everyone. Thank you all for joining us. Thank you, Nicole and Cook, for allowing us this forum to make this presentation on otologic cases. And I appreciate my panelists today for joining us. We have Dr. Dan Chu from Cincinnati Children's, Dr. Ken Lee from UT Southwestern, Dr. Carol Liu from Texas Children's, and Dr. Michael Hoa from Georgetown. Today we're going to start with Dr. Chu and his, so we're going to go with Dr. Lee first. Dr. Chu had some connectivity issues. So Dr. Lee, he's from UT Southwestern, and he's going to talk to us today, and he's about to start. Please.
Good morning. I guess they're pulling up my first slide here. I guess I'll go ahead and start by thanking Cook Medical for the invitation to participate in today's symposium. Today I'll be speaking on the topic of endoscopic tympanoplasty for anterior perforation with the anterior tuck technique. These are my disclosures. So I'm going to present parts of two different cases today. The first being a 12-year-old boy with a history of eustachian tube dysfunction and chronic suppurative otitis media. He's had multiple sets of ear tubes in the past, the most recent being 6 years ago when he had bilateral T-tubes placed. In the past 2 years, he's had no recent episodes of acute otitis media or otorrhea. And on exam, on the right side, we found a patent T-tube with the dry middle ear space, and on the left, a 35% anterior inferior perforation with the dry middle ear space. This is what the ear looked like under otoscopy. You can see that there is a anterior inferior perforation, roughly about 35% of the entire surface of the drum. There's some surrounding laryngeal sclerosis, and you'll notice a clean, dry middle ear space. T-tube in place, and on the left he had a mild sloping to a moderate conductive hearing loss. So there are challenges with these anterior tympanic membrane perforations, namely because we bring our grafts in through a posterior tympanomeatal flap. So we have to pull that graft in all the way to the anterior portions of the middle ear space, and oftentimes we have some difficulties or challenges securing that to the anterior limits of the middle ear space and on the undersurface of the tympanic membrane. Thus, if the graft happens to retract, you can leave a small gap anteriorly, which leads to a residual perforation. So to address this, multiple people have described a technique known as the anterior tuck technique. It's been described by Guilford and as well as by Primrose and Kerr, and something known as the Kerr flap anterior tuck technique. With this, you have an anterior tab or a tongue that's crafted in your graft, and that tab is then secured up against the anterior tympanomeatal flap. So this has been recently described nicely in a publication by Jeff Harris and his colleagues. It demonstrates that you make a small anterior canal incision, and then through that incision you can raise a small or narrow anterior tympanomeatal flap or tunnel. And then through this tunnel, if you create a tab on the anterior portion of your graft, you can pull that tab up through the tunnel and secure it to the anterior ear canal wall. Now, one of the advantages of the endoscope is that it enables us better view. I've been using this technique with the anterior tab since I was a fellow more than 15 years ago, typically using it for microscopic surgery. But there's actually additional advantages when you use this technique endoscopically. In this publication by Furukawa and colleagues in Japan, showing the same ears with both the microscope and endoscope, you can see that if you have a bony ledge in part of your ear canal, it can obstruct the view and prevent you from completely seeing the limits of the perforation. However, with an endoscope, you can place that endoscope beyond, or with the widened view, you can see the entire limits of the perforations, even if there's a significant bony overhang in the ear canal. Another advantage with total endoscopic ear surgery is that you don't necessarily need to make additional incisions, particularly if you're using a allograft, such as the Cook Biodesign graft. The Biodesign graft comes in a nice 2.5 by 2.5 square piece, which can be used easily for tympanoplasty. What I do is I cut that 2.5 by 2.5 piece into halves, and then you've got a primary and a backup in case anything should go wrong. You can shape these grafts however you would like, typically where the standard tympanoplasty or with that anterior tab for the anterior tuck technique. So typically what I do is once I create the tab, I will use a marking pen and mark the anterior tab blue, and this enables you to visualize it better under the microscope or under the endoscope. Once the tab is marked, dip it in saline like you would do for standardly using this graft, and then dry it on a block. So this is the ear seen endoscopically. As you recall, there was that anterior inferior perforation. There's some surrounding marginal sclerosis. We typically start by rimming the perforation or creating a fresh edge circumferentially. You'll notice that this posterior marginal sclerotic plaque is somewhat unstable. So typically I will remove that. Previously, I would remove all marginal sclerosis, but I've learned since my initial training that you don't necessarily need to remove all marginal sclerosis, as we'll demonstrate in the second case. So then once the perforation is completely rimmed, you can use a beaver round knife to create your anterior canal incision. And then I typically use a house round knife to elevate the tympanomeatal flaps. Now you'll notice here that despite the fact that we used lidocaine and epinephrine for hemostasis, this ear canal is somewhat oozy. There's a relatively large amount of blood. And so with the endoscopic ear surgery, because you don't have two hands available to use, can't suction behind this. As a result, there are various companies that have demonstrated specialized instruments like this suction round knife that has a suction port that can remove blood as you work. And with the suction round knife, you can see that as some of the blood is evacuated, you can improve your view as you're elevating the flap. So you'll continue to elevate the flap, bringing that in medially, and then once you get around the annulus and enter the middle ear space, then you can continue as you normally would. I typically use epinephrine soaked gel foam to place that into the flapper and portions of the ear as you're working to allow for improved hemostasis. I leave that in for a minute or two, then remove that, and then you can continue on with the case. Once you've completely raised that anterior tympanomeatal tunnel, you'll secure that up anteriorly, and then move on to making your posterior tympanomeatal flap. Once again, using the beaver round knife to make your canal incisions. I create a wide posterior tympanomeatal flap through a wider incision typically from 12 o'clock to 6 o'clock. Once that incision is made, you can then move on to elevating that flap again with a house round knife or with a suction round knife. So now we're using the suction round knife to elevate that posterior tympanomeatal flap. Bring that into the field. You get good evacuation of any blood that is in the area of the flap as you work. So once the flap is completely elevated, you can use a anus elevator to lift the ear canal skin and your native tympanic membrane anteriorly, so you can get good visualization and inspection of the middle ear space and contents. We're not going to show this here for the sake of time, but you'll do what you typically do to evaluate the middle ear space to look at the ossicular chain. Then you bring in your graft with that anterior tab marked with the surgical marking pen. Once I bring the graft in, I typically will use a ROSA needle or something more fine to do some fine adjustments and in terms of the positioning. You'll want to push the entire graft up anteriorly so that that anterior tab can be in the area where it'll be reachable through your anterior tympanomeatal tunnel. So as you can see here, you've got that purple marked tab pushing that in the middle ear space anteriorly and putting it in position where it can be reachable through your anterior tunnel. Once this is achieved, you'll pull your posterior tympanomeatal flap back, and then you can access that tab through the anterior tunnel. So once you've released all the tissue and you can visualize the marked tab, you can either grab it initially with the suction, or if you've got clear visualization, you can grab it with the cup forceps as demonstrated here. You'll grab that tab, pull it up along the anterior tympanomeatal tunnel, and then secure that against the anterior canal wall. Once that's achieved, you can reposition the skin of the ear canal up against that graft to secure that on that anterior wall. And then once that's achieved, you can reposition your posterior tympanomeatal flap. And for the sake of time, we won't go through the rest of this, but you'll just elevate the graft and native TM to pack your middle ear space. So let's move on to the second case. We'll describe a few different aspects of how this allograft can be used. So this case is of a 9-year-old girl with developmental delay and history of previous eustachian tube dysfunction and chronic suppurative otitis media. She had an expanding inferior tympanomeatal perforation, inferior tympanic membrane perforation after ear tube extrusion, and no recent episodes of otitis media. On exam, her right tympanic membrane was intact with a clear middle ear space, and on the left side, she had a 40% inferior perforation with the dry middle ear space. So if you look at her audiogram, because she was developmentally delayed, we were only able to get sound field, which demonstrated normal hearing. We did obtain an ABR intraoperatively prior to the start of the tympanoplasty that showed a mild conductive hearing loss on the left side. So this is a view of her ear with an endoscope intraoperatively. You'll notice here that she has that inferior perforation with some surrounding laryngeal sclerosis. Her perforation extends also posteriorly, so it encompasses about 40% of the entire surface of the tympanic membrane, mostly on the inferior aspects. So once again, similar to the first case, there's this posterior meringosclerotic plaque that is fairly unstable, so that was completely removed. The anterior tympanomeatal flap is a little bit more stable, so I've begun not removing all meringosclerosis. It can actually serve some additional structural support like cartilage tympanoplasty. So again, we make our anterior canal incisions with a beaver round knife. And then once the canal incision is completed, we can elevate that anterior tunnel with a round knife. Now you'll notice here that I'm using just a standard house round knife. I prefer to use this if the ear is particularly dry, if there isn't much oozing at all. The round knife is a little more low profile, so you can actually see around the instrument better. So if you don't necessarily need to suction blood, this is an instrument that I think is a little bit more amenable because it's less bulky. Now, once that anterior flap is elevated, we've already made our canal incisions, and then we're raising the posterior tympanomeatal flap. You'll notice that the posterior canal skin is pretty atrophic, and so this is a case of, as Miles Penzac would say, instead of how I do it, how I blew it. This is a case that didn't go ideally, and that posterior skin is pretty atrophic and gets pretty beaten up. But when this happens, if you've got a nice wide graft, you can line that entire bony surface and then allow the skin edges to lay over your graft, and it reepithelializes quite nicely. So fast forwarding, we've moved where we've already brought in our graft. Now we're going to pull that anterior tab up through our anterior tunnel. You can see here we've got that marked tab once again, and you can notice in this case as you pull that up, the graft positions itself quite nicely against the undersurface of the innate tympanic membrane. Once you get that in position with the anterior tab secured, you'll notice that there is a small gap inferiorly, and then just as you would with microscopic surgery, you want to position your graft optimally so that all aspects of the perforation are covered. You'll also want to tuck the graft in under the malleus so that you can anchor it to the acicular chain, and then allow for good connection once that reepithelializes for optimal hearing results. And then once you've got your graft in good position and you're happy with how everything is appearing in terms of good coverage, then you can elevate your graft and TM to pack the middle ear space. You'll do this as you would with a microscopic case. I use gel foam that has been essentially impregnated or soaked in floxin, and then I will press the gel foam between two pieces of telfa, a technique that I learned from Dan Chu when I was a fellow. And so you got antibiotic kind of in your gel foam, but it's not so wet so that it's expanded, and it makes it a little bit more difficult for the packing. Once you've got adequate amounts of gel foam in your middle ear space, especially even though you've got that anterior tab to secure it, you're going to want to really push that gel foam up anteriorly to kind of elevate the anterior portions of the graft. And then once you have the middle ear space adequately packed, and you just want to optimally position everything. As you'll recall, a lot of that skin was kind of macerated during the elevation, so you can kind of spread that to the side. With a microscopic case, when you reposition the lateral canal skin, it'll lay over your graft. However, with endoscopic, because you haven't elevated, you'll sometimes need to back elevate that. And if you got an adequately long graft, you can back elevate it and then lay your skin, the lateral skin, over the graft, and then it'll reepithelialize from a lateral to medial direction. So once you have that in good position, you can go ahead and pack the lateral ear canal with, once again, floxin soaked gel foam. Okay, so if we move on, basically the advantages of endoscopic tympanoplasty, less incisions. You can see here on the case on the left with endoscopic, you just have a cotton ball and a Band-Aid to hold that cotton ball in place, as opposed to our standard post-auricular approach where you typically will have a mastoid dressing. But what may be more important then is what's underneath the mastoid dressing. Even with total endoscopic ear surgery, if you harvest a fascial graft, you need to make an incision to harvest that graft. But with use of an allograft, you can avoid the making that post-auricular incision, and thus potentially lead to less post-operative pain. So in summary, the anterior tuck technique, the Guilford shade or curve flap, can be used for endoscopic tympanoplasty. Endoscopic tympanoplasty can be performed with the use of a Biodesign or other allograft material for a minimally invasive approach with only ear canal incisions for the surgery. And then minimally invasive approaches for tympanoplasty can allow for improved cosmesis with no post-auricular incision and ideally less pain. So with that, I'll stop and take any questions.
Regarding use of the anterior pull through with that much of anterior edge of the tympanic membrane remaining. There's some people would use it just primarily for marginal, truly marginal anterior marginal perforations. Do you have a gradation of where you actually will move to just do it from doing a underlay versus that anterior pull through, or?
I don't think I have a strict number or kind of the degree. It's something that I just make an intraoperative decision. If I feel, anytime that the perforation involves the anterior half of the inferior portion of the tympanic membrane, I will commonly use this tuck technique. It does provide additional security that the graft stays in place during the healing process.
Yeah, I found that's one of the things that my dear friend Ricardo Dita, rest in peace. He really touted that you need to really suspend that graft and make sure it's up against the annulus and the native TM. Otherwise, it's not going to work. So that's great. Thank you, Ken. And we'll come back to a few things later. We're going to move on to Dan Chu, who's the professor and Chief of Service at Cincinnati Children's. And Dan, take it away.
Thanks, Ken. I really appreciate being part of this, and sorry for the technical snafus. We went a little bit out of sequence. It probably would have made a lot more sense to go through the history and patient selection factors before jumping into the surgery, but I appreciate the flexibility here. So the chronic ear history, I think all of us have lived through the fact that if you miss certain key factors in the patient history, whether it's the type of problems they've been having or the previous surgeries and what might have been done to the ear in prior surgeries, it can either save you from getting into a lot of trouble in your own surgery or get you into a lot of trouble that you had to dig yourself out of because you haven't captured all the pertinent history beforehand. Other than being a speaker for Cook and by design, I really have no conflicts to declare in this one. I thought I'd start off with a case study just to highlight some of the things, and I hope this is a very typical experience for everybody, not just me. So this case involves a 4-year-old child that I picked up at that stage. Prior to this, he had had the very typical early acute otitis media history and had undergone his first set of tubes around 1.5 years of age. Those had extruded after about 12, 13 months. And then very quickly, he started coming back with 3 or 4 more bouts of acute otitis bilaterally. And so they replaced a second set of tubes. And looking through the chart, they didn't really discuss doing an adenoidectomy at that point, but that might have been one of the considerations for a repeat offender like this. When I had seen him, the right tube had already extruded and the drum had cleared up and healed intact, but the left side still had a tube that was intact and occasionally had bouts of otorrhea. We tried to wait a little while because I was debating whether or not this was a kid who had outgrown his otitis media problems or whether we had to think about taking additional steps. But by 6 years of age, we decided, you know what, let's just go ahead and take that tube out. He should be done with all of this. Unfortunately, he returned again with that left ear being very problematic. His parents noticed he didn't hear as well on that left side, and on exam, his pediatricians and we had noted that he was still building up fluid unilaterally on that left side. So we did go ahead and replace tubes, and notably we did bilateral tubes along with an adenoidectomy. And that might be one of the discussion points for us later on as well. If you had a child who's now 6.5 years of age, only showing unilateral left ear problems, at that stage, would you have still done bilateral tubes, which is probably our more common practice, or would you have selectively just done the left one along with the adenoidectomy? He seemed to do well, except for maybe once every few months getting a brief episode of drainage that cleared up with Ciprodex. But then his family tells me that they had a profuse drainage episode, and then they noticed the tube was in the drainage when they cleaned out his ear. I came in for follow-up that point, and you see this image of his eardrum, which shows a really large perforation, pretty ratty edged, but no active exam. And it's one of those scenarios where I suspect many of us have been in there where you think about chasing your tail and should I have put tubes back in this kid? Should I have done anything else? And then if we're thinking about patching up this ear at some point, what are the chances that he'll recur again? And then we'll go ahead and have to put a fresh tube through a regrafted eardrum. So those are some of the considerations we were thinking about. And in terms of this, when you start taking the history, I think it's helpful sometimes to just break it up into ear-specific factors at a very micro level, a little bit more granular, and then also patient-specific factors at a larger level. Here's a really typical perforation. And when we look about the ear-specific factors, some of the pictures here show you the things that we're thinking about. Is it a dry ear, or is it an ear that actually has active suppurative drainage coming out at the time? In contrast, this one in the top right corner shows a really sclerotic drum where you can see there's a ton of heavy calcified laryngosclerosis and an anterior perforation, but it's nice and dry. Don't see any signs of cholesteatoma or active discharge. And then also very relevant, obviously, is whether there's something like cholesteatoma going on. And in the bottom panels, you see this kind of ear would really take us in a different direction in terms of why this ear needs to be cleaned and what the relevant history is for that. Another obvious consideration is the hearing. And the first audiogram on the top left shows one of the really typical scenarios where somebody's got more of a low frequency conductive hearing loss that's typical for our kids with chronic otitis and maybe a perforation. But on the other side, the right-sided audiogram, you'll see a much more severe hearing loss with the air thresholds all the way down in the severe to profound range. There's a sensory neural component that's more in the moderate range. And so for this type of mixed hearing loss, one of the old school teachings is that if somebody goes into a surgery needing a hearing aid and comes out of surgery still needing a hearing aid, you should probably pause and think twice about why you're putting somebody through that surgery. Um, but the balancing point on that one that I wanted to include this audiogram for is if you talk to your audiologist and somebody has a mixed hearing loss like this, at that air conduction level that's so severe, they're sending a lot of power into that hearing aid, and it's a much more difficult hearing aid for them to manage. If you close that air bone gap and improve their hearing thresholds, it becomes a much easier hearing aid fit for that patient. Could also consider bone conduction type hearing aids for that type of person, but those are some of the considerations and histories that we go into. The prior surgery piece also is this double-edged sword. And when we talk to our trainees, It's obviously requisite, and it's your medical due diligence to check all the prior operative notes and try and get as much information as possible. But in total transparency, we also tell our trainees that never take the previous operative note as verbatim. Always take it with a grain of salt, because you never quite know what you're going to find inside the ear and if it matches up perfectly with what they thought they performed at the previous surgery. The status of how many times they've had surgeries is also very relevant, because particularly in this case, if somebody's had multiple ear surgeries and they've harvested a ton of fascia, periosteum, and tragus previously, you really may not have much convenient graft material to harvest. And so we do use something like a biodesign type graft material in those, and it can make the case a whole lot more efficient. Prior complications such as facial nerve weaknesses, even dehiscences that make it a little bit safer, are things that you can elevate that degree of safety just by taking an accurate history and capturing as much of the prior surgical information as possible. Age is a big one for us. I think the traditional teachings that we've all heard is that uh, sometimes as old as 7 years of age is a safer range when the kids have outgrown their younger episodes of acute otitis. And if you go ahead and make a repair of the eardrum, the chances that you'll have recurrent issues are less. But that's gets skewed a lot, and there's certainly a gray zone, at least for me, between 5 and 7. And Ken et al., I'd be very, very curious to hear what everybody's comfortable threshold is for how early you'd fix a perforation in a child. The other issues, more patient diffuse, we've all dealt with kids who have the obvious cleft palates as shown here. But I've been humbled sometimes by the submucous clefts, and even not a quite bifid uvula, but those that are broadened and still look like a single uvula. Um, and I thought I've done a good exam in clinic, but still when they get to the OR, you find that, oh, this was actually a very subtle palatal deformity with associated eustachian tube dysfunction. Adenoid disease we talked about is pretty mainstream for everybody. Our kids with those chronic rhinitis, sinusitis issues, and it may parlay into those environmental allergies just below that. Those kids definitely tend to have a greater tendency for chronic intermittent eustachian tube congestion and dysfunction. And in a similar line, our cystic fibrosis kids, immunodeficiencies, those with autoimmune type processes and Wegener's, all those things calculate into the decision making in chronic ear surgery. There's some softer factors that I'll wrap up with here, particularly when it comes to our younger patients. Um, I've sometimes underestimated how important it is for them to enjoy swimming. And at another level, there's some kids that we see who are just almost phobic about water in their ears due to the sensitivity. And so bathing becomes this tortuous event for the families, and providing them with a dry, safe ear definitely has a little bit more merit on those soft metrics than I used to be appreciative of. The other piece that our kids with chronic otitis and even milder hearing losses will display is more like academic performance fatigue, or I don't know if auditory fatigue is the right term for it, but our kids with even milder hearing losses will work harder than other kids to stay on task as well as hear all the information. During the school day, they'll do a lot of active listening as opposed to passive listening. And the way this manifests is the kids will come home, and even at an older age, pre-teenage, adolescent, they'll come home and need a nap because they've concentrated and worked so hard during the day. And then also social withdrawal for those same reasons. If the hearing difficulty is handicapping at all, particularly in multi-speaker complex listening environments, the kids will quickly learn that their friends are getting frustrated with them for chronically saying what. And as a result, they start to get a little bit more socially withdrawn. So we started looking for some of those softer factors, and that calculates into those decisions into whether to go ahead and repair kids or not. So Ken, I figured I'd wrap up there, and this part was probably the easiest of the talks to give. But curious what your thoughts are and some of those factors that would.
Yeah, I'll definitely open it up at the end to some of your questions that you had about like lower ages of tympanoplasty and whether not unilateral, bilateral tubes. But in general, I find that if I have an older child, like as you said, just all the disease was unilateral, I would probably just do a unilateral tube because of the risk of creating a hole in an ear that may never need that ventilation. And I do discuss it well with the parents that there's, we may still have to come back and do a tube on the other side, but because they've had no history of anything on the other side, I doubt that we will. So, but I do find I always worry about that. As you said, you put a tube in, you get a hole, and God forbid the hole was on the right side where you didn't have an issue before, and then you created
So
one.
true.
So that's always possible. But
How young will you
repair?
How young will you go on a dry perf?
So I take it from my things with like kids with traumatic perfs. I'll go down to 2-3 years of age. Just do it as long as they've had no history of recurrent ear issues leading up to that point. If someone with a history of recurrent ear issues, needing tubes, so forth, I usually, as long as the other ear has been doing really well, with no problems and no real issues, I've done it as young as like 4.5, 5. But I take it with a grain of salt because if there's a lot of drainage from an ear, if there's chronic problems, I might actually go earlier just to try to get that ear dry to close the eardrum. So yeah, it is a multifactorial consideration. Yeah. But and I'll let our other panelists chime in later on that same question. I'll bring it back around for them. But we'll move on to Dr. Liu, and thank you, Dan.
Thanks, Ken.
So Dr. Liu is at UT Southwestern, and she's going to talk to us a little bit about vesicular reconstruction.
Okay. Hi, Ken. Thank you to Cook Medical for inviting me for a talk. So I'm actually a little bit more south of Southwestern. I'm actually at Texas Children in Houston, although most people do think we're in Dallas sometimes. Okay, so today I would like to go through the endoscopic ossicular chain reconstruction. It is something that I really enjoy doing. And I find it definitely helps with the timing of the surgery and patient satisfaction. So I do have research funding with Otologix, which is for an otoscopy company. So whenever I do a ossicular chain reconstruction, the most common question I get is, don't you miss having two hands? And how do you maneuver the prosthesis? And how do you check for prosthetics positions? So we can go ahead and start with a case. This is a patient this is before his first surgery, which was found out to have a cholesteatoma isolated to the middle ear with erosion of the ossicles. So after the first stage of the surgery, this is his first ear surgery. As you can tell, there is a retraction pocket in the superior quadrant with a wide pearly mass in the middle ear. So after removal of the cholesteatoma and the ossicles, we're left with just an oval window with no incus and stapes. So in this case, and then this is his audiogram before the second surgery, which clearly showed that there is a severe conductive hearing loss as evidenced with missing ossicles. So this is after the second, at the beginning of the second surgery, where a cartilage graft was placed after surgery, and I did use the the bio design for as a underneath the cartilage for further reinforcement. So I generally inject lidocaine and epi, and I'll wait a couple minutes while I trim the ear canal hair before I proceed. Not all the cases able to be bloodless. Some cases do bleed more than the others. So I generally like to use a cotton ball to help in my elevation. I didn't always have a suction elevator. That was purchased by the hospital later day. When I first started, there wasn't one available. So what I find to use is use a cotton ball and use a suction intermittently and push the cotton ball along if possible, in combination with a round knife for elevation. And this also helps me in turn off elevation of the flap. And that's how it helps me with just one hand. The cotton ball, is this something that you need to talk to with your scrub tech to keep a really tight check off, which I do. And this because it's a second look, a stylastic sheet was removed that was placed on the first stage. And as you can tell, there was 2 isolated recurrence of cholesteatoma pearls. In this case, I did check the remainder of the epitympanum using a 30-degree scope, which at that time I didn't see any other cholesteatoma. The removal of the cholesteatoma, usually Rosen is kind of like my go-to instrument in addition to suction. And again, like if necessary, sometimes I'll use a cotton ball soaked in epinephrine to help with my hemostasis and dissection as needed. And you can kind of see as I re-enter the ear, there's actually 1 cotton ball, 2 cotton ball underneath the tympanomeatal flap, 1 superior, 1 inferior to the edge of the incision. That is actually how the tympanic membrane is getting held up. And usually I do dye my cotton ball using just a marker. I try methylene blue, but it's really messy and I tend to spill it at some point, making everything very blue. So in the OR, they just tend to dab the surgical marker into the epinephrine solution to mark it blue, so we know not to inject, because I use 1 to 1,000 epinephrine straight to achieve my hemostasis. And in this case, after the removal of the cholesteatoma, this is a portion where we're now moving on to the ossicular chain reconstruction. And again, I do like using the cotton ball for hemostasis. And afterward, first of all, is I heard stories of a prosthesis falling into the epitympanum, then all the way into the mastoid antrum in the past. So I always packed the epitympanum with Floxin or Ciprodex soaked gel foam into the epitympanum. And then the second step is I do pack slightly around where all around the oval window where I'm planning to put my prosthesis. And again, this is just helps in placement. And also if I work with a trainee, I'm not as worried about everything flying everywhere. With a prosthesis, I use a Grace Medical middle ear auto torp or porp as needed. And I do come with a sizer. So with a sizer is usually what I use first to figure out what size I want. I find it easier to place both the sizer and the prosthesis using a suction rather than with an alligator. Even though in this case I'm using alligator, but I find it easier to deliver it into the middle ear using a suction. And again, once it's in place, you can easily check for a round window reflex to see, and then to see if the prosthesis is fitting well. And in this case, I was, and I laid down the tympanomeatal flap to see if I'm happy with kind of like the bounce I'm getting with the prosthesis in place. And then in this case, I decided to put in a Dornhofer shoes to help further stabilize my torp. And this is a part where it is very small. So again, that's why I think it is important to pack the epitympanum first to make sure your prosthesis is not flying everywhere. And maneuvering of the prosthesis in the middle ear, again, I found both Rosen and suction are kind of like my best friend. In this case, there was some scar band over the oval window I was removing. And after I place the Donhofer shoe, I like to pack a little bit further off the middle ear with the gel foam to kind of get ready for my delivery of my torp. And this one is not my most pretty work as a torp keeps spinning on me. So again, I'm using a suction to adjust it to the position I like. I think this is a portion where I sometimes do miss a microscope where I have two hands, or this is a case where I'm hoping I have grown a third hand. There has been talks of using a scope holder to stabilize a scope, which allows you to use two hands. The downside is potentially if there's any movement from the patient, the scope will not move with you. So then it creates a concern, could you potentially causing some injury to the ear. For me, mainly just it's not available to me. And then I have gotten used to just using one hand. So in this patient, this is a before and after the placement of the torp. And unfortunately, he hasn't come back because of COVID for his post-op audiogram yet, but self-reported with improved hearing. So let's talk over another video. And then, so in this case, I skipped over the whole elevation part of the ear canal skin. So we're moving directly into the placement of the torp again. And again, like what I find is it is easier to place the prosthesis, personally, I think with a suction on the most broad portion of the torp, which allow easier kind of delivery directly into the oval window. And in this patient, I chose not to do a Donhofer, actually not because I chose to, because from the previous cholesteatoma, he has narrowing over the oval window. So I actually don't have enough room to place the Donhofer shoes. And then there are gel foam that's further up in the epitympanum. I know it doesn't look very much obvious, but there was some gel foam in the epitympanum. And in both this case, these are patients after cholesteatoma removal and coming back for the second look procedure. This patient needed to have, both of the patient actually was able to have the cholesteatoma removal through just the transcanal endoscopic ear approach. However, some of my patients who require the mastoid approach on the first stage for cholesteatoma removal, I will generally get a CT scan before I bring them back for endoscopic approach, second look plus the prosthesis placement, just to ensuring that we do not need to reopen the mastoid area if there are any area of concern. And then once you place a prosthesis, I put in more gel foam to, again, secure the torp in place. And depending on how the ear canal and the skin looks, sometimes I'll choose to place a second piece of bio design to help the tympanomeatal flap to lie down back to the ear canal more smoothly. I do find that with kids with any ear surgery, the canal skin tend to get thinner and thinner, and sometimes with elevation, a repeated elevation, the canal skin will get very macerated. In this kid, he actually did not have a cartilage placed with the first surgery. So in this one, I'm actually placing over a cartilage graft. And I peeled off the perichondrium on one end, and I left the tail on the ear canal to kind of secure and hold the cartilage in place. And then after I put in the cartilage graft, I come back and check for the torp, and I notice it has displaced slightly. So going back and double check the placement again is and placed in the right position. And then usually after it goes in the right the position that I wanted, you can keep checking, but generally they don't move too much afterward. In this case, I laid down the canal skin, and if needed, again, like I said, I will place a bow design. And then I take extra care to lay down the canal skin because it's very, I really don't want a iatrogenic cholesteatoma in the ear canal. So that's the end of my talk here.
Great, thank you very much. That's wonderful. I like how you pack around that prosthesis and really get it to stand up, and you make it look very easy. Um, uh, Great. I'm just going to, just for the sake of time, we will come back to some questions a little later. I will move on to Dr. Ho, who is at Georgetown, and he's a neurotologist there, and he's going to talk to us a little about a few other items. Michael?
Thank you, Ken. Thank you to Cook for having me here today. I don't, besides my the speaker fees for Cook, I'm a consultant for Cochlear. That's not relevant, but that's about it for my disclosures. And I'll begin with the first case. So this is a 13-year-old, or sorry, 9-year-old presented me with a conductive hearing loss on the left side. And this is what his eardrum looked like on exam. You know, this is, and this is kind of what his hearing test looked like. So, you know, mild to moderate conductive hearing loss. And this is what we saw on a CT scan, kind of a lesion, soft tissue lesion between the malleus and the middle and the where the stapes footplate was. And sorry, this is going a little fast, but this is what we think is a classic congenital cholesteatoma in the tympanic region. And there are a couple of different classification systems, but I'm just putting them there just so that you get a sense. So we're elevating the the tympanomeatal flap. Like many, when we first started using this technique, I used just cotton balls and a standard round knife, but over time I've used more of these suction round knives and gotten a set for myself at our hospitals, and they're useful. They're great for resident training, actually, and it's primarily one of the reasons I do use them, because they're really helpful in that regards. So we're raising up the tympanomeatal flap, and we get to the middle ear space, and you see this kind of yellowish lesion here. And I put some cottons at the tops here, at the edges of the tympanomeatal flap, to help secure it and help provide some hemostasis. And we're looking at this lesion. This is the chord tympani here. And I'm going to look back here in a sec, just to see if whether there's any lesion tracking back there. I'm pretty quick to convert if I see something going back past the first half of the lateral semicircular canal. Luckily here we don't, but I always look and make sure that we're that we don't have to do that. So this is the back of the lesion here. So and this is the eroded incus here. Okay, so the cord is going between the eroded incus and the malleus. Okay, and this is that lesion here. And interestingly, it wasn't all just skin. There was, you know, what appeared to be some cholesterol granuloma-like material. I'm taking out a little bit of the ear canal, or curating the scutum area there, just to get a little bit better access and look. You know, I tend to find that the endoscopic instruments are are nice for when you can see it with a 30 degree, but maybe with a 45. But once you go beyond that, like anything you can really see with that you're seeing with a 45, sometimes you really can't reach with your instrument. So you have to. So my workhorses are really the 0 and the 30 degrees here. So we're moving moving this cholesteatoma forward so that we can I can make sure that I'm seeing kind of the backside of it. And you know, unfortunately, this isn't as pretty. You know, I'm breaking up the cholesteatoma a little bit, as you see. And now that we've kind of really removed most of the cholesteatoma, you still see this eroded incus here. Okay. There's kind of some, you'll see in a second, there's a little bit of granulation tissue right over the oval window. We're going to clean that and get a nice view of that oval window. Now that's okay. And I'm gently teasing all that out. I'll grab that in a second. And really, you know, the bloodiest parts of endoscopic ear surgery are the front. They're the tympanomeatal flap elevation, and just some oozing from the top ends, and use of cotton soaked in adrenaline is really helpful. And I'll remove this in a second, just kind of teasing it out a little bit so that I can grab it. Right. Okay, so now you see that oval window just right there. Okay. Yeah. So now what I'm doing is I'm kind of amputating that eroded incus a little bit more so that I have a clear shot with my prosthesis, but I'm keeping it. I'm not taking it out. I think I like to preserve the ossicles. They preserve the height of the drum, and they're good markers, so to speak. So, and I thought this was a good teaching tool for the resident as far as kind of teaching them the having the not just the frame of reference with the sizing prosthesis, but just to see what the where the natural area of the drum is. And now I'm putting in a prosthesis that's sized appropriately here. In this case, I'm using a Beaugerub Alto Grace prosthesis, a total. I'm tucking that handle under the handle of the malleus there. And then I've harvested a tragal cartilage graft that I'm going to place on top of this. And if you do have some gaps, so I in this case I took just some of the tragal perichondrium I had on the one side, and you know, noticed, and as you notice, you know, re-inspecting where your prosthesis is important. You know, gel foam is helpful, but you know, if a prosthesis is really going to shift, I think you really need to see how it lies down. So I tend to I do less gel foam now, and I haven't noticed that I have as many problems doing that, but there are times when I use a little bit more. And here you see a little bit of gap, but I cover that with a little bit of the tragal perichondrium. And then that's it. And essentially we just pack the rest of the ear canal, and we're done. Okay. So we can go to and I will advance here. Go to the next one. So this is a slightly different case. This is actually an older gentleman. This is a case that I did with my residents at the VA, and I really just want to highlight the fact that you know, our residents who we work with, you know, they I think they take a while to really see well with the microscope, and I think we all did early on. But they really, this really is a great teaching tool, and I find that they learn a lot, and they do progress a fair amount over time. So it's been great to watch as my residents kind of work, and we work together and they learn. So this is gratifying. Um, so this is a 69-year-old gentleman with a posterior retraction in the mid and a mass in the middle ear space. These are my residents who worked on this case. I just wanted to say they did a great job. So this is what they found initially: a little retraction pocket here, and you know, he really didn't have a hearing loss, and had been seen outside, and you know, he asked us, you know, should I, you know, what should we do? And I said, well, it could be a very early cholesteatoma, and that's what we suspected. And so, you know, that's what the CT looked like. So we're elevating the flap, and this is my resident elevating the flap. So it's not me. I want to make sure that you guys know that, you know, these tools and this setup, it's great for residents. Getting the set was, you know, made it, I think, easier for residents to really see that this was a great tool and a great case. And you know, we have a nice mix in our practice with a couple of our attendings doing a lot more microscopic work, and myself doing more endoscopic work. So they get a nice mix of the two techniques, and so forth. So, all right, we're raising that flap. Okay. And gonna release the little band in a second. This is not the chorda, it's actually just the little part of the annulus. We'll release that. Okay, so now you're seeing the incus right there, stapes, and then malleus is right there. Okay, and in a second, you'll see, focus on right here. This is that little lesion we're seeing on the CT scan. It's a cholesteatoma diving between your malleus and your incus. We're gently kind of dissecting around that, making sure we've got a nice plane free in front of the incus. You'll see it a little bit better in just a second. All right, so you see that skin, that pearly skin kind of diving between. And one of the nice tools that I like using here is the number 3 suction round knife. It's the equivalent of like a house little dissecting knife that's more obtuse, and it's great for dissecting right on the malleus handle and over ossicles. There's a non-suction round knife version too. I have both sets, or both types, and I use them. They're nice. So I'm just dissecting it the cholesteatoma way, and getting it off between the two. And what we're going to see after I kind of free this cholesteatoma out is that it was kind of diving through that little retraction pocket. So we end up with a, you know, small little perforation. And we're taking the cholesteatoma out. Second. Actually get stuck on the scope side. Okay, and I'm pulling the last of that cholesteatoma here. Okay, so now look, you know, I'm gonna inspect a little bit with my Thomason dissector. That's a workhorse for my endoscopic technique. It's great tool, and then we're okay. So now I'm just removing the cottons that adrenaline soaked cottons that I had used in place to just provide some hemostasis and bolstering the tympanic membrane. Looking a little closer, this is the incus. I'm introducing my biodesign graft here. And the thing I like about the biodesign graft in these cases for these the smaller purses, it's a little thicker. It adheres to that drum, you know, and especially when you're working transcanal, if you don't want to take a graft and it's small, this is a nice thing to have. So yeah, and just making sure it's kind of touched up, and then we're packing the rest of the ear canal, and we're done.
Great. Thank you, Michael. All right, so we're going to just go on to sort of my little sort of presentation here, because it'll get all of our panelists included, and then we'll address some of the questions that came in through the chat during this time period. So, all right. So my only disclosure is really it's a consultant for Cook Medical. So when I do the preparation of the ear canal, there's lots of people that do many different things to try to get the ear canal to reduce bleeding risk, and so some people use 1 to 1,000 epinephrine. Sorry, 1 to 50,000 epinephrine. I've heard some people even using 1 to 10,000 epi straight without any lidocaine. And then our panelists have talked about using cottonoids with epinephrine. I heard that with Dr. Liu, she was using some the marking pen in the liquid because methylene blue gets really so messy. I found the same thing, and so what I've tried to do actually is I use fluorescein tabs in the epinephrine, and it makes it nice and colored that way. My concern with the marking pen is always that it's not really approved to be inside the body. So I feel that I don't want to introduce something that is not necessarily supposed to be there. Fluorescein is a nice little easy thing. It's not very messy, and they literally get the tab from ophthalmology. They just put it right in the epinephrine. I saw a lot of people are using have trimmed the vibrissae in the ear canal. I usually wait to while I'm waiting for the injections to take effect. I'll actually just use them to trim that away, and then I place them in a slight reverse trim Bellenberg as well. Interesting. I did notice with Ken, you placed a stitch. Is it in the tragus? I guess to pull the tragus forward.
Yeah, can you hear me? Yeah, I was actually forgot to comment on that. I was going to mention that it's one thing that you can notice. I do that. It opens up the ear canal quite a bit. And I learned that from our colleagues in Japan who do that routinely.
Okay. Yeah. Do you use a particular stitch for that?
I use a 2-0 silk, and then I'll just grab a bit of the cartilage of the tragus, and then I, secure that with a snap on the drape.
Okay. And then does anyone do anything different or otherwise to prepare the ear canal?
Yeah, so I guess for my cottonoids, I'm just using a 1 to 5,000 adrenaline cotton, but yeah, I think it's pretty straightforward there.
I think your sequence of steps is pretty similar, Ken. And Terabici has a stitch that he sometimes puts in at the external meatus as well to help hold it back for the same reason that Ken does.
His comes from behind usually. Yeah.
And I have tried because a nurse complained about cotton balls, although they got really good at counting it for me. I have been complaining about keeping track of how many cotton balls I use throughout the surgeries. So previously, I have tried to use the neural pledges from neurosurgery, the baby ones. The problem is they actually shed more than you think they're going to shed. So the fibers from the neural pledges actually keep coming off. And then the string itself created more of an issue toward the end. So that was one thing I did try and didn't work out well for me.
Yeah, American Surgical that are not very, that don't really have a lot of fiber in them. So, and I, much to the chagrin of my scrubs, I do have them cut the tabs, the strings off. But since it does have a radio opaque detector in it, they're much happier with that than me using cotton, because they're always concerned about my leaving that in the ear. So yeah, it's something you might consider. All right. But so we saw them elevating flaps using the suction elevators. We've kind of adapted this fish adapter and then a Bishop Harmon 19 gauge irrigator. Actually, it's a cannulation used for irrigation in ophthalmology, and it's kind of oval and flat, so you can actually just use that to elevate your flat if you don't have a suction elevator in a special set for endoscopic ear. So that's kind of something we've sort of put together and utilized and found that works very well. And you can steal that off the ophthalmology sets. And now I'll skip over this one a little because I know people have shown already those suction elevators. Anyone use anything else in particular for elevating the flap other than the suction elevators that have been mentioned? And
yeah, I think this continually evolves for us, Ken. And one of the other things we've been trying lately is this distal chip tip endoscope that has a retractable suction on it and extendable. So that puts the suction back in your left hand, which I don't know, might be appropriate in some of these cases.
Great.
Yeah, we're just starting to trial that too, Dan. I'm very interested to see how it, how good it is for that. But I think it's funny how we've evolved to not to be kind of one-handed surgeons for these endoscopic cases, and kind of restoring some of that too.
Great. All right. So to my next little slide. All right. So yeah, and the things that usually comes up and I hear from people and asking about is what's your favorite endoscope to use. There are people that tout using a 0 degree, other ones use 30 degree. As was alluded to, the 45 and 70s really get you angled, but there are not a lot of tools that we have right now in our armamentarium to really reach where these can see. Do you have, for each of you, what's your go-to endoscope, particular diameter you like to use? Use a 0 or a 30? Dan, what do you do for?
I'm very much a 0 degree kind of scope guy, and only for very specific indications, looking up in the attic, looking back in towards the antrum. Will I go to an angled scope? I think it's
use a 3 millimeter
especially
scope,
hard
or
for our
use
trainees. Obviously, if we can, I'll try to stay with the 4 millimeter. Just so much better light, as well as visualization. But as we get smaller, particularly in our younger kids, then you're forced to go down to the 3 millimeter.
Ken, any difference?
No, I follow the same plan as Dan. I use a 3 millimeter 0 degree scope for pretty much most of my endoscopic ear surgery. I will reach for a 30 degree, as Dan said, when you have cholesteatoma that's going up in the attic, or if you need to look sort of around the corners. But that's really, the workhorse is a 0 degree scope.
Okay. Carol?
Yeah, I agree. I use a 3 millimeter actually because pediatric patient tend to just have smaller ear canal, so I don't have a lot of rooms. The only thing is just that I always just ask everyone to remember the newer STORT system will know how to adjust the brightness, but we still have some older system in the hospital. So usually you have to remember to turn down the brightness down to a small scope setting, or else you get this lovely glare in the middle of your view every time you put a camera in. And 30 degrees is kind of usually when I'm checking the epitympanum for cholesteatoma. But I agree, sometimes it's frustrating. You can see the cholesteatoma, but you cannot get the cholesteatoma back out.
And how about you, Michael?
I think for those,
Yeah, I don't disagree here. I think the workhorse for me is the 0 degree and the 30 degree for attic and looking towards the antrum and so forth. So, but I'm really, if I see it tracking back past that anterior half of the lateral semicircular canal, a lesion or something, I'm quick to convert. You need to balance time and speed and so forth. So I think we talk about this often.
So there's a couple questions
Ken,
from the audience. Yep. Go ahead.
And Ken, I was going to say that part about using angled scopes and not being able to reach. One of the most helpful thing is something I got from Walter and Brandon down in Dallas at Ken's colleagues, where they take disposable suctions. And the benefit of them, as opposed to our Shooknick suctions that our SPD folks get really pissed off when I bend them, is you can take the disposable ones and bend them as long to the custom shape that you need. And it actually lets you get back, to that back edge of the horizontal canal or way up into the anterior epitympanum. When you know it's there, you can see it, but our standard instruments just don't reach.
Great suggestion. Yeah, so there was a bunch of questions that came in from the chat, from the audience, and so just try to get through some of those. One was directed at Dr. Lee, regards to placement of a slit in the graft. Do you make an accommodation for that for the malleus? Do you place a slit or not place a slit?
Yeah, that's a great question. Thank you for that question. Slit was actually described in the original kerr flap. I typically do not use a slit when I'm doing the anterior tuck technique. And the reason for that is that you don't know exactly where you're going to position the graft, because you're not exactly sure how much you need to pull that up the anterior tympanomeatal tunnel. So where you make the slit may not be where you want it relative to the malleus. I do that slit in certain cases when, particularly if there's a near total perforation, you need to get good securing of the graft up kind of very high or in the superior aspects. And so in that case, the slit is helpful, but typically not when I'm doing that anterior tuck technique.
Great. There was a question that came in for Dr. Liu. Do you always use a cartilage graft lateral to the torp or porp? And have you ever used the hydroxyapatite without a cartilage graft at the top of the for the porp or torp has a hydroxyapatite head?
I think with my training was always to do it with a cartilage graft. I think with a hydroxyapatite, the torp, in theory, you could. I'm having a hard time deviating from all the training I have so far. So personally, I do like having cartilage graft.
Anyone from the panel do anything different with use of cartilage graft?
I do, Ken. If somebody's got a really beautifully aerated middle ear, and let's say it was a traumatic ossicular disruption and you did an ossiculoplasty, I don't necessarily feel compelled to use cartilage. Obviously, like we've all tried, if you've got a type 3 retracted ear, you've got a cartilage graft, essentially the whole drum, to get the thing not to extrude.
I had a case of a child that I did a reconstruction with the Dornhofer with the hydroxyapatite and didn't use cartilage. This was early on in my career and had a beautiful result, 0 degree air-bone gap. And then slowly over the years, his eustachian tube dysfunction kind of recurred, and then the drums kind of sucked down over the hydroxyapatite. So since then, I've been using at least a thin layer of cartilage over the lateral portion of the prosthesis, regardless of what I use.
Yeah, I think Dan's comments early on about really kind of understanding the history of our patients is really important in this regards, because you can definitely see changes over time, and if you see them for long enough, you know, a lot of these problems declare themselves towards the end. So yeah, I tend to use cartilage fairly liberally. So.
Michael, do you have any experience with doing endoscopic stapedectomies?
So I don't do my stapes endoscopically. I do all the vast majority of my stapes under local. I trained with John House and Rick Friedman and Bill Slattery and Daryl Brackman, and you know that's kind of how we do it. But also, I do a lot of medical mission work, and when I'm on medical missions, I'm doing all my surgeries under local with very little sedation. So it's that's just kind of what I've done. But you know, I have colleagues obviously who do it, and you do get a great view. I think it's great for teaching and for visualization. Just for me, for my practice, I don't. So
Dan, I don't know if you do any stapes up where you are, but what's your thoughts?
I do. And I'm at that stage where I'm trying to think, is it better than what I used to do with a microscope? You know, that's the key variable. I've had to adapt the technique, you know, up to doing this. I typically do a stapedectomy and we'll remove 2/3, 3/4 of the foot plate, whatever comes atraumatically, and then use a perichondrial graft. Also use a Robinson bucket handle prosthesis. So the modification in technique is after you get your perichondrium down over your stapedectomy, actually we'll seat the head of the prosthesis and flip the bucket handle over the incus. And the foot of the prosthesis may be a little bit out of position, but it's resting on your perichondrium. And then what you do is you gradually slide the graft to pull the prosthesis into the oval window niche. Because you don't have that second hand to lift up on the incus, that's the technique that I've kind of evolved to.
Great, great. All right.
And you know, with the so I found, so actually we took some biodesign grafts with us on a medical mission where we were doing lots of stapes, and you know, occasionally you get a tear, you know, a small perforation when you're doing a tympanoplasty, and you know, so these are great kind of small grafts that you can, the graft just sticks against the tympanic membrane, you lay it down. So if you so there's no additional other prep. It saves you time, and time is really on those missions. It's key because we're doing a lot more stapes there on some of those missions. We're probably doing, you know, 20, maybe 20 a day, so to speak, in some cases. So between two surgeons. So so we have to be fast. So the biodesign graft saves us time in those cases. So yeah.
Yeah, biodesign. I mean, I've been using this porcine xenograft for a while, even before it was biodesign, and it's probably 15 plus, it's about 15 years or so, and it's really I found it to be a nice graft because it's thin, it's strong, it goes away. You can even lay it on the lateral aspect of the ear canal. And I saw, I think it was Carol, you lifted up and back elevated your canal skin. If you lay it just against the canal skin, it won't create like a skin inclusion cyst on the ear canal. It just goes away, that lateral portion. So it's very handy to use in many different ways, and you don't need the separate incision. But yeah, just to go briefly through, we don't have much more time, but what's each of your experience with it? And do you ever notice granulation tissue in the ear canal with the use of biodesign?
Haven't had an issue. And Nicole had asked a question as to whether it was first choice, and Certainly if you're doing a endoscopic transcanal procedure and not planning on any external incision, it's a huge efficiency improver and very convenient to use. If you're going post-auricular, then I don't really see a need to not take autologous fascia while you're there.
Ken?
Yeah, I haven't noticed any granulation tissue issue. I like doing the bio design. A big part is actually for teaching. I feel like I'm more comfortable to let the resident or fellows at least try cutting a shape and placing it in. Just knowing that with that 2.5 centimeter square, I can usually get 3 graft out of it. So if the fellow and resident was unable to place their choice or the shape they cut was not ideal, I always feel like there's a backup to it.
The one place where I think biodesign suffers a little bit sometimes are where you have a really purulent ear and there's lots of inflammation. I find that that's not a good place to use the biodesign graft, and I tend to use either cartilage or fascia in those cases, because I've seen those kinds of cases just break down over time with just the biodesign graft. So I do think about that when I look and think about which case is good for a biodesign graft.
I can comment that I pretty much use biodesign on every case if I'm just going in the canal with canal incisions. It obviates the need for an additional incision to harvest graft. But if I do make a post-auricular incision for various reasons, I'm already made that decision, I will typically use their own fascia for my graft. And I've not seen any granulation. That was the other aspect or comment part of that question, was that I've not seen any granulation post-operatively with the use of a biodesign graft.
Great. All right, well, thank you all. I'm going to turn it back over to Nicole.
Thank you so much to all of our speakers and for the audience questions. Please be sure to take some time to complete the survey that will be sent after the event so we can continue to learn and provide quality education. I hope you enjoy the upcoming AAO if you're in LA and the rest of your weekend. Stay safe, everyone.